Bismillah ar-Rahman ar-Rahim. Welcome everyone. This is Ahmed Reda, lecturer of cardiovascular medicine, Mansour University, and this presentation is about heart failure in a case-based approach. Our case is Mr. Sameh, who is 66 years old male, and he is a retiree and was admitted to the hospital accompanied by his daughter. When admitted, patient complained of shortness of breath for 2 weeks and was worsening on the day of admission. So this patient is coming to you by an acute onset with progressive course of dyspnea. What questions would you ask in order to explore his symptoms? Here we come to the point of analyzing a complaint of dyspnea. This complaint of dyspnea should be thought as a way of is it of chest origin, is it of cardiac origin, is it of another extra cardiac origin like a systemic one. Chest origin may be all chest diseases, the bronchial asthma, the COPD, the pneumonia, the pleural effusion, and what else? All cardiac disorders, if they lead to heart failure, will produce cardiac dyspnea, and other causes of dyspnea rather than the chest and cardiac, like the anemia, the fever, the cytotoxicosis, diabetic ketoacidosis, the severe obesity, all can cause dyspnea. But if our patient is coming with acute onset and progressive course of dyspnea, we should think of a cause that is an emergent one. So we will analyze this dyspnea to know if it is of chest origin or cardiac origin. And the main characteristic of a dyspnea that comes from a cardiac origin is its relation to position. So we will ask the patient, have you had shortness of breath in the past? Do you have a diagnosis of COPD or asthma? So we are looking for a chest cause. When did the shortness of breath start? So if it started like 1 hour ago and the patient is coming to you in the emergency department, so you should think of attention pneumothorax or acute pulmonary embolism. If it is for 1 week, so you are thinking of a case of progressive heart failure. If this dyspnea is with a patient for like 3 months, 1 year, so you should think of a much benign cause like an obesity. Are you short of breath at rest or only during exertion? Here you come to another point of analysis of dyspnea, which is grading of the dyspnea. We go for the NYHA classification, which depends on the ordinary activity of the patient. So we ask the patient about his ordinary activity, what he does in his everyday life, what is his work, what is the nature of his job, and then where he is staying. He is staying on which floor, is he going up stairs or using the elevator. Then we have an idea about his ordinary activities, then we go, so this dyspnea now is occurring with an activity that is the usual one or less than the usual one, or it's just occurring with an extraordinary effort, so he's just not conditioned to this level of activity. Again, have you had any other symptoms such as cough, fever, or wheezes? Have you coughed up blood? Again, you are thinking about the associated manifestations of chest symptoms, and then you go to the cardiac manifestations, starting with the analysis with presence of another causes or another symptomatology of cardiac disease like chest pain. So if he has any chest pain before or any heart problem before, now we are going to inquire the patient about all the risk factors of a cardiovascular disease: the hypertension, diabetes, the dyslipidemia, obesity, smoking, the family history, all the risk factors for cardiovascular disease, or what we are making a risk portfolio of our patient. So what are the important points in each point of history, in each an item of the history, to know if a patient is coming to you with acute onset and progressive course of dyspnea? So the first one is previous cardiac history, previous respiratory or disease or lung disease, previous surgeries and allergies, the drug history, especially the inhalers, the social history about the living situation, smoking, and then the systemic inquiry about all symptoms in other body systems. So back to Mr. Sameh, he also experienced shortness of breath while performing simple tasks such as walking short distance, occurred while lying down. Subsequently, he hasn't ambulated from bed for several days except to use the restroom. So from this paragraph, we are gonna analyze this dyspnea and grade it according to NYHA classification. So we're just walking short distance, and again it's now occurring when lying down, so it is dyspnea at rest. It is NYHA class 4. He also reported leg swelling at his side that was of new onset and worsening. So this leg swelling, we call it the edema lower limb. So this patient now is presenting with congestive symptoms. This dyspnea can be a non-congestive symptom, and this edema lower limb may be a systemic congestive symptom. What else? He smokes 2 to 3 cigarettes per day for 35 years. Again, he's still a mild smoker. He was also diagnosed with hypertension 10 years ago. He was also diagnosed with missed anterior wall ischemia 1 year ago with PCI to LED using 2 drug-eluting stents. Analyzing each word. So this slide is giving you in the first part the NYHA class of the dyspnea. Then it is giving you another associated cardiac symptomatology, which is the edema lower limb, and then adding to the risk portfolio of the patient, which is the smoking and hypertension. And the last one, what is a structural heart disease that may be in this patient? This patient had a previous anterior MI. He has a family history that reveals his father has died of ischemic heart disease 4 years ago, while his brother has hypertension. So cardiovascular disease and ischemic heart disease runs in his families, and especially in males. Mr. Sameh was admitted to the hospital for the same presentation 3 months ago. So this is about the past history and family history. So let's revise some terminology. The first one is dyspnea, which is difficulty of breathing simply, or sopnia, that is dyspnea that is exaggerated by lying flat and relieved by leaning forward or by sitting down, and paroxysmal nocturnal dyspnea, which is severe acute dyspnea that occur 1 to 2 hours after falling in sleep. So paroxysmal nocturnal dyspnea, by the way, is very basic mnemonic of mechanisms that share in occurrence of paroxysmal nocturnal dyspnea. The fluid redistribution while lying flat, the fluid is redistributed to lungs. More fluid is going to be accumulated in the lung. This is one mechanism. The other one is the increase in left atrial pressure and the fall in oxygen tension during sleep. So with somehow relaxation of respiration, the oxygen tension in blood decreases, and the left atrial pressure increases, that will lead to pulmonary congestion and paroxysmal nocturnal dyspnea. This is one. Also, there may be due to the parasympathetic dominance occurring through sleep. There may be dilatation of the precapillary sphincters with reabsorption of fluid from tissues to plasma, and the last one is the increased venous return to the heart. So back to Mr. Sameh. Mr. Sameh has a previous history of a cardiac problem, which is the anterior wall myocardial infarction that narrated that obligated him to do a percutaneous coronary intervention and the insertion of 2 stents in the left anterior artery, and he has a risk portfolio that is a significant one for a cardiovascular disease, which is hypertension and smoking, and he has a family history of cardiovascular disease, and now he is presenting to you with dyspnea that is increasing to become a grade 4-1 with edema lower limb. What is the most likely unifying diagnosis? The most likely unifying diagnosis is heart failure. How do you know this dyspnea is of heart failure origin? I see this patient has a marked risk for cardiovascular disease, a previous structural heart disease, a dyspnea that is increasing, and a sign, an objective sign of congestive symptom, which is the edema lower limb. So this patient is in heart failure. So this is the first one. How to diagnose a case of heart failure? Heart failure is formed of two pumps, of two arms, I'm sorry. The function of the cardiac muscle is to fill with blood from venous system and then to pump it in the arterial system. So heart failure is just failure of filling that leads to congestion. This congestion on the left side will cause the lung congestion, and on the right side will cause a systemic congestion. And the other failure to pump will lead to the low cardiac output symptoms. So the lung congestive symptoms are just the presentation of Mr. Saleh: dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. The systemic congestive symptoms are the edema lower limbs, the ascites, the hepatomegaly, and the congested neck veins and the pleural effusion. So, if you think this patient has a congestive symptoms, and this dyspnea is due to lung congestion, and you see there is another congestive symptoms and signs in this patient, what are you going to look for specifically? Specifically, you will look for the neck veins, the hepatojugular reflex, to auscultate the heart to hear the gallop, which is the triple rhythm with tachycardia, and to look for the apical pulsation site to find this placed laterally, so you suggest a cardiomegaly or a valvular heart disease. Here is about the classification of dyspnea and the classification of heart failure. This NYHA classification of dyspnea is based on the ordinary activity of the patient, coming from 1, that is dyspnea occurring at an extraordinary effort, 2, on ordinary effort, 3, less than ordinary effort, and 4, dyspnea at rest. And the other one, the newer one, is the American one, staging of heart failure, going from stage A, that is a patient that has a risk for developing a structural heart disease. Stage B is a patient with a structural heart disease already, but he has no symptoms of heart failure. Stage C is a patient with symptomatic heart failure with reduced exercise tolerance. And the stage D is when the heart failure is refractory to all kinds of medication, and now we are looking for the very advanced treatment. So, if this case has dyspnea and orthopnea and edema lower limb, and you think he has a structural heart disease, so I think this patient has a heart failure. What are the other symptoms you would like to examine to be sure of your diagnosis and to affect your management? Actually, you will look for all the body systems, but the first important one is the vital signs. Let's read the vital signs of Mr. Saime. The blood pressure is 156 over 92 mm mercury. The heart rate is 116 beats per minute and it is regular. The patient is tachypneic and saturation is 94 and he has a normal temperature. So this patient is slightly hypertensive or uncontrolled hypertension, by the way, and he has tachycardia that is regular one, and this regular tachycardia is going with his decompensation of his heart failure state, and the patient is tachypneic, but his saturation again is 94. His physical signs revealed elevated jugular venous pressure with beating edema lower limb grade 2. The cardiac examination showed a pan-systolic murmur over the apex. This murmur is usually due to a functional mitral regurg due to the left ventricular dilatation, and chest auscultation revealed bilateral fine basal lung crepitations. So this patient is a congested one. He is in congestive heart failure now. He is in acutely decompensated heart failure because his dyspnea is class 4. The next question would be, what are the additional investigations would you like for this patient? You will look for bedside tests, the ECG, blood tests like the CBC, fasting blood glucose, urea and electrolytes, renal function test, liver function test, troponin, TSH, and the most important one is N-terminal proBNP, and then you look for the imaging by the chest X-ray, the echocardiography, and the CT pulmonary angiography for a case of dyspnea. This is his ECG showing sinus tachycardia, normal rhythm, and pathological Q wave in V1, 2, and 3. So this patient has an old anterior myocardial infarction. His laboratory research showed severely elevated proBNP and a troponin level that is negative. His chest X-ray showed pulmonary congestion with hilar enlargement and cephalization of pulmonary veins and increased bronchovascular marking with preserved post-costophrenic angle. There is no pleural effusion and there is prominent aortic knuckle going with his chronic hypertension for 10 years, and lastly there is cardiomegaly. The cardiothoracic ratio is like more than 2/3 of the transverse diameter of his chest. So these are the findings by this chest X-ray. Now we go for his echocardiography, and this echocardiography is a 2D echocardiography that reveals severe dilatation of the left ventricle with mal-coapted mitral valve leaflets due to the severe dilatation of the left ventricle, and this is the cause of the patient's severe mitral regurg, and this again is an M mode over his very dilated LV in the cross section, showing a dilated dimensions plus an impairment in the ejection fraction. This patient has an ejection fraction of 30%, so you're sure of heart failure. What if this patient comes with the same clinical presentation and you do an echocardiography and you find his ejection fraction 45? What if he comes with the same presentation and the ejection fraction now is 60? Heart failure is a clinical diagnosis. Its definition starts with saying a clinical syndrome characterized by inability of the heart to pump blood to tissues as the metabolic requirements, and this definition doesn't include the ejection fraction at all. So a heart failure patient may present with an ejection fraction that is less than 40, and now we call it HFrEF, heart failure with reduced ejection fraction, or might present with a mild reduction in the ejection fraction from 41 to 49, and now we call it heart failure with mildly reduced ejection fraction, HFmrEF, and maybe in a normal ejection fraction is an ejection fraction of more than 50, and we call it HFpEF, heart failure with preserved ejection fraction. After you diagnose the patient with heart failure, this is only the functional diagnosis, and then you are looking for an etiological diagnosis. What are the risk factors that I'm gonna look for? I'm just gonna look for all the cardiovascular disease, because every one of them, if left untreated or neglected or we failed in its treatment, will lead to the clinical heart failure. Symptoms: stage C, the symptomatic heart failure, or stage D, the refractory one. We know this patient has symptoms of heart failure, so he is stage C or D. We didn't try the medical treatment yet, so he is stage C. So this patient has a heart failure with reduced ejection fraction because his ejection fraction is less than 30. He has a biventricular failure because we have signs of systemic congestion that denotes right side failure and signs of lung congestion that denotes left side failure. So he has biventricular failure, or the old name congestive heart failure. He is heart failure stage C, and his dyspnea is class 4 because it is occurring at rest, and the etiological diagnosis is ischemic cardiomyopathy due to the previous anterior wall myocardial infarction. So, what is your therapeutic strategy? Focus with me. I'm not telling you to just narrate the medications we give. We are looking for a strategy to treat this patient, and we have three main items in treating every case with decompensated heart failure. The first one is optimization of volume state. Second one is to address and treat reversible factors. And the third one is to continue or initiate guidelines directed medical therapy. What I mean by the first one, which is optimization of volume state, your patient may be congested like Mr. Sameh, or he may present mainly with the another arm of heart failure, which is low cardiac output symptoms, and then your patient may be dehydrated or his tissues are hypoperfused, so we are giving him fluids. So we are optimizing the fluid state. This patient, we assess the volume state of this patient. He is congested, he is euvolemic, he is dehydrated, and we optimize the volume state if we need. The next one is to look for a reversible cause. A reversible cause may be an acute coronary syndrome that needs the specific treatment of acute coronary syndrome, an intervening arrhythmia. This patient entered in paroxysmal atrial fibrillation, and this led to him falling in heart failure in a patient with previous structural heart disease. Or this patient may have an extra cardiac problem like has a chest infection, a pulmonary embolism, whatever. This all can lead to a stressful condition of the circulation if this heart is borderline function, not only the ejection fraction but all the contractile and the diastolic function. This patient may present with heart failure. So I should look for the cause or the risk factor and treat it. And the last one is to reach the patient to the level that his hemodynamics are stable to start the guidelines directed medical therapy of heart failure, as I mentioned before. So the guidelines directed medical therapy are the Fantastic Four, SRNA, beta blocker, MRA, and dapagliflozin, and then we add the diuretic according to the clinical use. We just replace the word diuretic by saying optimization of the volume state. The Fantastic Four are the angiotensin converting enzyme inhibitor or the angiotensin receptor neprilysin inhibitor. What is the angiotensin receptor neprilysin inhibitor, or what we call the ARNI? They are a combination of sacubitril and valsartan. Valsartan is one of the angiotensin receptor blockers, and sacubitril is a neprilysin inhibitor. What is the neprilysin? Neprilysin is the enzyme that degrades the natriuretic peptides. You know, in a patient with heart failure, the atrial receptors feel stretching of the atria due to the volume overload. They secrete the natriuretic peptides from the atria and from the ventricle. And this natriuretic peptide causes natriuresis and diuresis, so they relieve the symptoms of heart failure and congestion. So the neprilysin enzyme is the one that degrades the peptides. So if we give an inhibitory of the enzyme, so we reserve the peptides to do their action. This is the first one. Beta blocker, and the best one in heart failure is carvedilol. Then mineralocorticoid receptor antagonist, that is spironolactone and irinotecan. And the last one, which is sodium glucose cotransporter 2 inhibitor, the dapagliflozins and the dapagliflozins, that are mainly antidiabetic drugs, but they are used in treatment of heart failure with reduced ejection fraction, and they may have a role in other types of heart failure. What about the surgical option for such patient? He may need insertion of a cardiac resynchronization therapy device. He may need revascularization, valve replacement, an extracorporeal membrane oxygenation, or heart transplantation. This is all about this case with heart failure. All I want you to remember is when you face a case of dyspnea, think of it: is it a chest cause, a cardiac cause, and or an extra cardiac cause? If it is chest or cardiac, you look for the other associated symptoms to guide you. If this dyspnea is due to heart failure, it should be accompanied by either low cardiac output symptoms or another congestive symptoms. The congestive symptoms should include the systemic symptoms and the non-congestive symptoms. If you diagnose a patient with heart failure, you should look for the etiology of his heart failure. What is the cause of his structural heart disease? This is one. And then what is the precipitating factor that led this compensated patient with structural heart disease to become symptomatic now, and how to treat it, and then to stabilize your patient and to optimize his volume state, and then to start the guidelines directed medical therapy formed of the Fantastic Four, SGLT2 inhibitor, ACE or ARNI, beta blocker, and MRA. Thank you.